Diaphragm pacing is a remarkable invention of neurotechnology. Surgeons implant electrodes around the phrenic nerve, which are connected to receivers in the diaphragm. Later, when the patient heals, an external transmitter sends current to stimulate the electrode several times a minute so that the phrenic nerve makes the diaphragm contract and air is drawn into the lungs.
This is not like a heart pacemaker that is isolated and completely runs by itself. This really is more like a ventilator, but instead of using a machine to drive air in and out, it basically uses the child's own diaphragm.
Most people have never heard of diaphragm pacing, partly because it's a recent phenomenon. The late Christopher Reeve had one of the very first pacer implants in 2003, and it actually worked a little differently than the pacers now used in children. Diaphragm pacing is not widely used, mainly because the condition called CCHS is rare, as are high spinal cord injuries that require full-time ventilation for more than a few months. But for those who can use diaphragm pacing, like Jim Harrison, the impact can be liberating.
Definitely increases your freedom exponentially, so that's something I would always vote for.
You've got a little battery-operated box. One of our patients went backpacking in the High Sierras because she had diaphragm pacers. She could put this in a backpack. This allowed a level of freedom that would be pretty much unheard of with some of the other techniques, for example.
So you've heard electrodes and receivers are implanted into the body. Here's what it looks like on the outside. There's the transmitter, powered by 9-volt batteries, where you set the strength of the current that's sent to the phrenic nerve on the right side and left side. And there are the antennae, which are placed and taped over and around the implanted receivers. So now we'll move on to the timeline for getting the pacers implanted and ready to go.
First thing that needs to be done, obviously, is to surgically implant the phrenic nerve electrodes and the receivers. Here at Children's Hospital Los Angeles, our surgeons are able to do that thoracoscopically, which means that you don't have huge incisions, you have a number of smaller ones. These children need to remain in the hospital usually about 4 days or so after that surgery. And then we send them home. We don't actually start the pacing for a period of time, although we have tested all the equipment during the surgery when we put it in to be sure that it in fact works. We generally let all this stuff heal for about 2 months. Okay? And part of the reason for that is that whenever you implant a foreign body into somebody, that is this electrode, against the phrenic nerve, it generates some scar tissue around it. And that scar tissue does form between the electrode and the nerve. The thickness of that scar tissue is ultimately going to be one of the things that dictates how much current or how much voltage you need. So we just let this process happen and get done with, rather than trying to start pacing right away and have to change settings every day. Doesn't make much sense.
So after a couple of months of healing, the patient comes back to the hospital for a night or two to start the gradual training process. Meet Melinda Riccitelli, whose daughter Sarah has pacers.
And you work with the doctor to determine what setting you're going to need to get adequate ventilation. And you go through a procedure of placing the antennas in place, turning on the transmitter, and dialing an amplitude setting until you see inhalation. So amplitude is the term we use to describe the electrical signal that's coming out of the transmitter that's going to interact with the phrenic nerve to produce a breath. Okay, everyone's is different. Okay, so there's not any set, okay, this is a 13-year-old girl who weighs 100 pounds, she needs an amplitude of 3. It's different for everyone, and the right and left side is different. So when you are determining amplitude threshold for the very first time, you start with an amplitude of 0. And again, this transmitter has a little dial on it, it has numbers on it, and you just set it to an amplitude of 0. You place the antenna over the receiver, you tape it down into place, and you start dialing up the amplitude.
It's all right.
You do that until you get until you feel a contraction. If you have your hand over the antenna, you can actually feel it vibrate a little bit, the device. And you should be looking at the patient and seeing an inhalation. You should be able to see that. And then once the doctor has decided what that number is going to be, then that's what you use on a regular basis, night to night to night, to maintain ventilation.
Melinda learned about these procedures from her doctor and healthcare team. Most parents will develop these skills with a little experience. We continue with how the body is trained to use pacing.
Now, what we found is that when we start pacing, usually pacing only works for about an hour to an hour and a half. So what's happening is that the diaphragm is, in a sense, fatiguing. That is, it's not able to continue to contract for the same amount of current for a much longer period of time than that.
This is called diaphragmatic fatigue, a very natural response to stimulating the diaphragm muscle.
This, I think, is very analogous to training for a marathon. If you wanted to train for a marathon, you wouldn't go out and run the full marathon. Or if you did manage to do it, you certainly wouldn't do it the next day. You would start with a small amount, a small distance, and gradually increase that.
You start by just doing an hour of pacing a night for about a week. And then you start increasing that time by a half an hour or 60 minutes until you get up to a full night where you have efficient, stable, diaphragmatic pacers that you can see by oxygen levels, carbon dioxide levels are all stable. And so that usually takes about 3 months in a typical patient, and it just takes time. During the training part, you still have in place the trach and the ventilator. And so you use a dual system. You pace for as much as you can, and then when you start to see pacing not be effective, you switch them back to the ventilator, and you do the ventilator the rest of the night. Then you start again the next night. And so, I did I had nursing. I didn't do this on my own, so we had a nurse there monitoring blood gases all night. And so we would watch it and determine, this night we might get 40 minutes, the next night we might get 45 minutes. And then, so again, everyone is a little bit unique. And so when I say you start with an hour a day, that's a generality.
Now this is, it's physiology, it's where technology meets physiology, it's just the way it is. We can't get this to happen any faster. But even children who are quadriplegics seem to be able to train at about this rate. So I think that's pretty good evidence that this is not a disorder, it's just natural muscle response to a new stimuli that it has to adapt to.
And that leads us right into the technology part, which will require a little troubleshooting from time to time when the pacers stop working.
The most critical thing is not to panic, okay? I think that, and that's very hard not to do, I know that. But we have to talk, when we talk about kids with CCHS, the typical CCHS kid, if they have any kind of equipment failure, can just be, you wake them up, because they're very normal when they're awake. And so you can get everything stabilized and they're safe. If you're not dealing with a CCHS kid or a typical CCHS child or patient or some other kind of condition that would use pacers, then you have to realize that with the Avery system is a dual independent system. And so each side works independent of the other side, and it would be rare that both sides would go down. And so one side will always be working, and that gives you some stability.
We've had the experience that when a number of our children have had failures of one side or the other of their pacer, that we have been able to get them to adequately ventilate using one side, but we would like to see them and be sure that that's the case. So this does need to be done in conjunction with their medical experts.
But we're getting a little ahead of ourselves. What do you do when the pacers aren't working as they should? Melinda's methodical approach is to first check the transmitter.
The first thing you would look for is simple stuff. Did the amplitude dials get reset? Did they get bumped? Did they get turned down? Those are the kind of things that are an easy fix. It happened to us. Sarah came in one night, my pacers aren't working. Okay, well, let's look at it. So we look at it and we notice that, the pacers were turned way down. And so she just wasn't getting enough signal to cause the contraction. If that happens, you can obviously see that. You just reset it to the normal setting, place them all over the receivers and start pacing. Everything's fine. And so look for that first.
Here's a tip to prevent that problem. Simply apply some paper tape across the bottom of the amplitude dials so they can't be accidentally moved.
If you look at everything and all the dials seem to be set right, then you'd want to check the batteries. And so the battery compartment is in the bottom of the machine. And so you'll remove the bottom of the device and you'll pop out the batteries and place new batteries in. Okay. Push them back in. Stabilize. Let me put the bottom back on. Never take the battery out if the transmitter is on. It will damage the machine. So we have our transmitter. We've replaced the battery now. Now we're trying to, so we have fresh batteries. Everything should be fine if that's the problem. You can tell if your battery is working because when the transmitters are on, you just click the button. There are two flashing buttons that you should be looking for. One is identified B for battery. The other is A for antenna. They are both flashing. If you replace the battery and you're still having a problem with the battery, light not flashing, it tells you then that you probably have a problem with the battery connector. And so what happens is, and this is the most common form of failure with the device, is these little wires crack that are inside there. They snap and break, and so what happens then, the battery doesn't work. So at that point, you do have to send the device to Avery to repair.
If you have fresh batteries and the battery wires are okay, you would check the antenna.
What you would first look for is cracks or breaks in the antenna that would indicate that there was a problem. Again, when you have your transmitter on, the antenna light should be flashing. That tells you that your antenna is working. If that's not flashing, you're going to figure out, well, you do have some problem with your antenna. One way to assess that is with a radio. And if you take your radio and set to 1600, if the antenna is working, you should have a pulse. That you can hear. That tells you that the antenna is working.
You may have noticed a piece of blue tape on one of the antenna. That's a trick that Melinda and Sarah used to distinguish one side from the other. They put blue painter's tape on the right antenna and on the transmitter dial for the right side so they see which is which. Now back to the antenna test.
If you did not hear that pulsing, then what you would want to do is put a new antenna on. And what you do is the antennas just pull out. We usually carry replacement antennas in our equipment bag, and it can only go on one way. If you can look at the connections, you put it back on, your antenna's working.
So these are the easy steps you can take to see if you have an easily solvable problem. You might even make yourself a list of things to check. Make sure of the amplitude settings, that they haven't been accidentally changed. Check the batteries. Check the battery wires. Check the antenna for breaks or cracks. Check the antenna with a transistor radio. And certainly, call your doctor.
In general, they need to call their doctor, who's their diaphragm pacer expert, to sort out exactly where to go, what to test. Usually we'll need to see these children to do some sort of testing to try and figure out if this is an easily solved problem, for example, just a break in an antenna wire, or whether this represents something that's more serious, for example, a problem with one of the internal components that would require surgical replacement.
Sometimes there are problems with diaphragm pacing that require adjustments to the equipment. One involves sensitivity to the equipment settings.
When we started using the machine as Avery sent it from their factory, we determined an amplitude of, say, 3.1. At 3.1, okay, that amplitude was not strong enough to create inhalation. And yet when you move to 3.2, which is the next notch up on the dial, you contract so hard that the diaphragm is so stimulated that that force just pulls down the airway, and so you have an obstructed airway now. Bottom line is you don't have air coming in, you don't have a breath. Again, you don't go through this whole procedure not to get a breath.
In Melinda and Sarah's case, they sent the transmitter back to the manufacturer and they modified the settings to allow for finer control. Now, this is where it pays to have a helpful medical team, including the equipment company, to troubleshoot problems and make pacing work. Another challenge that might come up is upper airway obstruction. If a strong diaphragm contraction is the reason for the upper airway obstruction, the transmitter can sometimes be adjusted so the contraction and the breath are more gentle.
And then to compensate for that gentler breath, we increase the rate. Talking with Dr. Keynes, a typical rate would be 12 for a patient. She's at 15. And so you have a longer, softer breath, but you have more of them. So again, you're able to maintain your oxygen levels and your carbon dioxide gases, which is what you're trying to do when you breathe.
So after several years of pacing, the verdict from Melinda and Sarah?
I think that it was the right decision for us to go with diaphragmatic pacers. I think that we like it. We like to travel. It makes it much easier.
It was hard to get used to at first, and I went through a little bit of a depression because it wasn't a normal breath. It wasn't how my friends and how everyone else around me breathed. It wasn't how my parents breathed. It's only how I breathe. So it was kind of like, wow, it's a downer. But after a while, I got kind of used to it. I kind of accepted the fact this is how I have to be. So might as well just get used to it. So I did, and it's fine. Like, it helps me travel a lot. Like, I went to Pennsylvania by myself, my brother, and Mom didn't have to come with me because I didn't have these big luggage-filled stuff. I just had this little machine to go with me. It opens up whole new possibilities.
And coming up in our final two chapters, a cautionary tale and a remarkable success story of a young man who's used pacers for years.